This is Brian Wormers recording a lecture for medical nursing on nursing care of patients with hematological disorders. Here are learning objectives that you can review on your own. First, we're going to talk about red blood cells. So when we think about that, we think about anemia. So common ones are going to be like sickle cell disease or iron deficiency. So sickle cell disease, you can kind of see over here on this image over here, in that when we get a regular cell, low oxygenation can cause it to have this crescent shape, and then that causes it to jam up. One of the things I like to tell people is think about like a lazy river when you're tubing in a river or down in a water park. If you're in a nice round cell, this kind of bounces along and everything goes well. Now, if you try to take a kayak into that place, it's going to all bounce up and it's going to cause problems. So that's kind of the theory for what's going on with this. So that's probably the major one for as a result of red blood cell destruction changes. We can also have things such as G6PD, which is a genetic disability. Otherwise, we can look at immunohemolytic anemia, which is less common. Other things that we talk about, so iron deficiency is probably the biggest one worldwide, and this is from a lack of iron in diet, obviously. Other things we can think about would be other nutritional ones, such as vitamin B12 or folic acid deficiency. And then we can talk about aplastic anemia, where I've commonly seen that from secondary to chemotherapy or cancer. So sickle cell disease, in a little bit more detail. So get a good history on these patients. Have they ever had a crisis before? What has caused it? What has been the resolution for this? Were they stressed out? Were they dehydrated? Were they sitting for a long period of time? And then what did it take to resolve it? Lots of hydration, oxygenation, pain meds. So in this patient, look for the physical assessment, clinical manifestations. What are they feeling this time? What's going on with them? Are they short of breath? Are they having pain in their legs, claudication, different things like that? And then look at psychosocial aspects as well. What is this doing to their life and how are they coping with this? Lab findings, we can do electrophoresis for that hemoglobin S. We can also look at H and H counts, looking at reticulocyte counts to see how many immature cells are being out there, and we can look at the breakdown of those cells and the byproduct of bilirubin. We can look at some imaging, but it's usually not as effective as the other one. Intervention, so they typically have pain. This can be resolved with some opioids. Generally speaking, we're using some morphine because that has a vasodilatation effect. Other things we can do is compare pain to previous episodes. Is this similar or is this worse? And then hydrating, lots of fluids, trying to open up that vasculature to resolve any of this clotting and problems of getting those cells wedged in the vasculature. We can also look at, trying to prevent sepsis and multi-organ damage by looking for infection markers, maybe even possibly going into prophylactic antibiotics, although I don't currently see that a lot. And then, as always, good hand washing and PPE. And then we're really trying to prevent further hypoxic events by trying to prevent whatever caused this one. So anemias, so iron deficiency is probably one of the biggest ones that I've ever seen out of this group. It's poor absorption of iron into the system, or it's an inadequate diet. So hopefully just a replacement, an oral replacement of this, or even an injection can be beneficial. Otherwise, we can get vitamin B12 deficiency. This often is from diets lacking in dairy or related to surgical resections of the small bowel. So this can be evident by the jaundiced appearance. And then the textbook thing is glossitis, which is a beefy red tongue. They tend to be fatigued and they have some weight loss. And so basically what we do with that is we replace it just like we do with the iron. We can either do it through oral, but if they've got a small bowel resection, we might have to do it IM. Folic acid, once again, this is caused by inadequate intake or malabsorption or other drugs or alcohol causing disruption of the absorption of this. So what we can do with this is, do replacements. And lastly here, aplastic anemia is failure of the bone marrow to make cells. We can transfuse if severe. We can do immunosuppressants if the body is reacting and killing those cells. And then if we are having lots of damage to those cells from the spleen, if they're going through the spleen and getting chewed up, so to speak, then we can take out that spleen. So too much red blood cells is often called, one of which is called polycythemia vera. This is too thick, causes hypertension, causes hypoxia. So just think of it as too much sludge. It's hard to get blood flow into the tiny areas, and oftentimes it is often underdiagnosed because it's not super common. Oftentimes they have a ruddy appearance. They look really kind of reddish. And what we do for this is we treat them with hydration. We can do apheresis and pull some of that fluid out. And we're doing whatever we can to try and promote venous return. Can get hereditary hemochromatosis, but this is less common, as well as myelodysplastic syndromes. Myelodysplastic syndrome can be an early form of leukemias and cancer cells, and I think there's an 80% chance of diagnosed with MDS. Then it prolongs and goes within 5 years into a cancer state. WBCs, so you talk about issues with that. So I mentioned leukemia before, but this is a cancer of uncontrolled production of WBCs taking over. Oftentimes, what you see then is that your body just wants to make the white blood cells and it fails to make the other blood cells, and that can become a problem. There are four major types depending on what cells are involved and what's preceded the disease. So you can look at those below. We want to assess for risk factors. Have they been exposed to radiation, recent illnesses or infection, any problems with bleeding lately, or any weakness or fatigue. Physical assessment, some of the things that we might see would be cardiac changes related to anemia, so like increased heart rate, trying to compensate. Respiratory changes related to anemia as well as possible infection. Because not only you make a lot of WBCs, but they're usually not as functional until you are in a state of deficiency. You might see skin changes. Oftentimes I've seen bruising related because your platelet counts are down. And then intestinal changes from bleeding or fatigue related to lack of coagulation. Some psychosocial assessments, how is this affecting your life, of course. Then lab findings, the big ones that we're going to be doing would be a CBC and looking at those cells. We can also look at clotting factors to see how fast that body is clotting, and then we can do a bone marrow biopsy to see how those cells are being made. Interventions. So we want to prevent infections either from an auto contamination from themselves, from one site to another site, or from an outside source. Drug therapy, often this is a round of chemotherapy. This is going to include induction. So we're trying to, induce them into a state of remission. So we're not seeing this production. Then go into consolidation. So we're trying to promote a cure at this point in time. They may have stem cell transplant at this time after we knock down their counts, or it might let the body kind of come back and heal itself. And then after that, then it's maintenance. During this time period, we want to watch them for any bleeding because that would be bad if the counts are bad. And then conserve their energy because they don't have a lot of RBCs. Malignant lymphomas, some of the major ones that I want to know about this one is Hodgkin's lymphoma, which basically has a Reed-Sternberg cell, although it's a non-Hodgkin lymphoma, which does not. There's also multiple myeloma, which maybe some of you guys have seen on your clinicals, and basically this is an overgrown B lymphocyte within that bone marrow. So Hodgkin's lymphoma is probably a large lymphatic node. It tends to be symptomless. It usually doesn't bother them. It's just kind of a big thing where you can palpate the node. Staging is done to try and figure out what kind of treatment they're going to need. Labs are often done, as we said before, CBCs, electrolytes, looking at those cells. We're going to look at liver and kidney function tests to see what our perfusion is like. We're going to look for ESR for any inflammation. We're going to look for bone marrow aspiration to see what cells are being made. We can do scans such as a CT or even a PET scan and look to see where these cells are all at. Treatment is radiation, generally speaking, or it can be chemotherapy. And then we really need to do good nursing care about side effects and looking at those decreased counts and trying to protect our patients. Non-Hodgkin's lymphoma, this is swollen lymph nodes. Um, Once again, this can be a painless presentation. Presents very similar to Hodgkin's. However, it's lacking that Reed Sternberg cell. This can be a little bit more aggressive though, and we do treat it very similar with chemotherapy, radiation. But then we can do stem cell transplants as well. Multiple myeloma may be asymptomatic, but they might have a high protein level. Tend to be fatigued. They have some anemia, some bone pain. They might an early sign of this might be a pathological fracture. So they have the fracture, and then we notice that they've got cancer cells related to that. Some of the diagnostics we can do with that, of course, would be bone marrow and checking the serum or the urine for protein in that. And then, of course, looking at the bone and see if there's any osteolytic lesions. We can do staging and prognosis based off those lab values, and then interventions. It's looking at protease inhibitors, immunomodulating drugs, trying to calm that body down. Of course, managing side effects of this, pain management, and then treating any bone disease as necessary. So, like with vitamin D um, and increasing calcium. Coagulation disorders can include platelet disorders. Oftentimes, this can be an autoimmune or we used to call this ITP. Now it's more autoimmune thrombocytopenia purpura. Basically, the platelet count is normal, but while it's circulating, it's getting reduced for some reason. And oftentimes, your body is destroying it. The theory behind this is that after like a respiratory infection or some kind of an infection, your body is just kind of in overdrive, and these platelets get coated with an antibody, which makes it seem like a foreign molecule, and your body destroys it. You can get PTP, which is very similar to this. However, what you're seeing is that you get clumping of your platelets, and so in some areas you're going to be hyper, and some of these areas, of course, if they're all clumped over in this other area, they'll be low. And so this can cause lots of problems because this can cause stroke-like symptoms as well as clotting disorders. So you won't clot when you need. Other clotting factor disorders, so hemophiliac, we can talk about factor 8 and factor 9. And so this is A and B, and those are probably the most common ones. But basically, it's got an inability to form a stable fiber clot. So one common myth is that these patients just don't bleed out like crazy. They're not faster bleeders. It's just they don't stop bleeding as fast. Um, it takes them a lot longer to form a clot. We'd also get heparin-induced thrombocytopenia, and this is one of the major reasons why we're trying to get rid of heparin as much as possible in the hospital setting. But this can cause a decrease in platelet count, and then if you decrease your platelet count, you're going to have problems.